You're listening to Stellar Success, Leveling Up for Medical Pros with Dr. Tudor Francu. Join us as we explore how medical professionals can achieve stellar success in all areas of life. It's time to level up.
Dr. Rachel Edwards, how are you?
Yeah, wonderful. And yourself?
Very good, very good. Thanks for coming over to our podcast. What do you think it's the main reason you're successful in what you're doing?
Well, I'm 100% type A, so I want to give 100% in everything I do. And that shows people around you that you want to do the best you can, and you try to be a good role model so everyone around you wants to also give 100%. They see you doing it. They're like, well, I don't want her to be the only person giving 100%. So they try to as well. And I think it makes a whole community of success when you do that.
Yeah, absolutely. Um, so tell us a little bit about your journey. Where did you start? How was the journey and what are you doing now?
Okay. So grew up in North St. Louis County. I want to be a doctor since high school. And I was 100% type A. So played varsity basketball, did track. I was in honor society. I was student president. I went to WashU undergrad in St. Louis and majored in chemistry. I continued playing basketball. I did track. My junior year in basketball, we won the national championship, Division III. And then I was all conference in shot put and discus in my senior year in college. Then I went to Washington University Medical School in St. Louis. I wanted to initially become a family practitioner until the fourth month of my fourth year when I did a rotation in ER and loved it. And I switched everything around. I switched all my second half of my medical school fourth year and did orthopedic surgery rotation. I did trauma surgery rotation. I did cardiothoracic ICU, switched everything around and was able to get in interviews at several ER residency programs. And I ended up matriculating into Barnes Jewish Hospital emergency medicine program in St. Louis. So all my education has been in St. Louis. Did a 4-year program there, loved it. And I started working at my current hospital in 2006, moonlighting. I became the medical director in 2009 to 2015. They had a new company that they hired to run the emergency department in 2015. So I stopped being a director, went back to just being a staff ER position for 9 years. And then starting this year, I became the ER medical director again. So
Very
I was
nice.
my predecessor, successor, and I was before and after him in this role.
Very nice. It takes a certain mentality of a doctor to be an ER physician. It's a different animal.
Yes, it is.
What do you think it's the most, I would say, rewarding skill or habit that you need to have to be like this?
Um, Rewarding skill. Well, one thing is you have to be able to be in a very intense environment where you can be interrupted every minute with an EKG or a patient's crashing or a patient wants to talk to you or a code blue. So you have to be able to tolerate an environment where you can get interrupted every minute. The most rewarding for me is just knowing that I saved a patient's life or found a critical diagnosis or turned a sick patient around and then getting the gratitude from the family. That's one of the most rewarding things. And people remember, I've been in this hospital for 20 years or 19 years, and I live in the community. So people remember, hey, doctor, you saved my mom's life 5 years ago. Hey, you stitched up my cousin 10 years ago. They still remember that stuff. And that's very rewarding to hear stories like that in the community.
Yeah, that's true. I think the reputation that you create for yourself, especially in a specialty like this with life and death situations, it's very important. And I mean, it goes both ways, right? You also remember patients that you saved. And what do you think a new graduate, a new medical school graduate should have like personality wise traits that could fit into the specialty?
Well, you have to, I mean, one thing about the ER physician and our community is we work really close with the nurses. The nurses will save you. They will notice when your patient has an acute change in their vital signs or something different, or they'll tell you, oh, the family member said this, or something that EMS missed. So you want to make sure you have good collaboration with your nurses. I know that you're a doctor and we're much more educated than nurses, but the nurses will save you. The nurses know a lot. So you really make sure you know how to work as a team with your nurses, and just give yourself grace. You see a patient, you might not know exactly what's going on, but if you can at least, ABCs, airway, breathing, circulation, keep them alive, figure out what's going on. That will save you in the end. You don't have to know everything initially, but as long as you can keep the patient alive, keep working your progress, figure out what's going on, that will help you. So collaboration and giving yourself grace.
Yeah, I don't think there is a more close relationship between the physicians and the nursing staff more than in the
Oh,
emergency room.
absolutely.
Um, like you said, this relationship can make or break your success as a doctor. But I think, for someone who comes out of medical school and wants to go into residency, um, what do you think about this emergency room residency rather than a rotation in different, programs? Because I believe right now it's all, it's most of the people that want to do something surgical or anesthesia or anything related, they do a
Mhm.
rotation in the emergency room for, several months or whatever. But what about the residency program in emergency room? What do you think about that?
One of the things in the emergency medicine program is you do a lot of rotations off service where you learn how to do procedures. So we do rotations in the ICU where we learn how to put in central lines, intubate, put in art lines, chest tubes, work in the pediatric ICU to see how you do the same kind of thing for pediatrics. So I think a lot of the off services help with learning procedures. And then you put everything together in the ER when you have trauma patients and working in the ER and doing shift work. Just that's one thing we're supposed to be um, masters at a few things and kind of know all, but we're really masters at keeping the patient alive, resuscitation, and doing procedures. So I think the off service rotations help a lot with learning our procedures, getting those down.
Yeah. Um, do you have any stories of things that didn't really go well in your career? Um, you save a lot of lives, but things happen. Can you give us examples of things that kind of didn't necessarily work out and you learn a lot from them?
I have one case. We had a 29-year-old gentleman who was hit by a drunk driver, car, um, on a rural road. The police officers found the drunk driver, but his car was in an embankment off to the side, and it was at nighttime. So they saw the drunk driver, arrested him, but they didn't see his car till about an hour later. So he got a hold of his car. His wife worked in our ER, and even though he was about 45 minutes away, she wanted him to be brought to our ER. So they drove him to our ER. It had been an hour. So by the time I got him, he'd been about an hour and a half. So big guy, he was heart rate was really fast. He was complaining about severe chest pain, and it was a trauma. So they asked me, did I want the paramedics to just drive him up to the trauma center, which was about 35 minutes away. They were not flying that day due to weather. And I said, no, let's just do an X-ray real quick, make sure he doesn't have a collapse lung. And if he does not have a collapse lung, we'll go ahead and have you take him up to the trauma hospital. So that was in the day where we took an X-ray, and I looked at the X-ray on the light board. I was able to walk down the hall, look at the X-ray on the light board to see the collapsed lung. So he didn't have a collapsed lung. And then I heard a nurse saying, "Oh, he's getting better. His heart rate is going down. He's getting better." I knew that was uh, a bad sign. So I walked over to him. I ran over to him. His heart rate was dropping, and blood pressure was dropping, and we started CPR on him. We gave him blood. We did CPR, and we did everything we could, but we couldn't get him back. His wife was in the room at the time, so he was in his late 20s. She was in her mid 20s. They had two little kids, and he died. Um,
Yeah.
I will run that through it's early in my career. I run it through my mind about was there anything I could have did differently? If I sent him up to the trauma center sooner, give him more blood, but I don't think there's anything else I could have did sooner. The fact that it had been an hour and a half after his trauma, I don't think anything else I could have did better for him. But it ran through my mind all that night. And then the ER, somebody dies, you keep going, you can keep going. I was a solo coverage at night, so he died, and we had next room was a 4-year-old kid with a cough. So it keeps seeing patients, but it was that whole. You can imagine that whole shift. We were all very distraught because the woman worked there, and that was her husband. It was very, very sad.
Yeah. Yeah, it's a tough job. But you need to keep going too. And I think part of the success in this field is that you need to basically be able to jump from one patient to another, in a matter of minutes, because I mean, you can deal with cases like this all night long, one after another, and
Yeah.
you
Hmm.
can't just you know kind of stop. You need to keep going. So do you have any kind of advice, I would say, for medical students that want to do emergency room in terms of how do they prep their studies and internships and, all the training, basically?
I would say take advantage of the off service rotation. Take advantage of learning as much as you can about ear, nose, and throat, orthopedic surgery, pediatric. Make sure you, because, in the ER, we see everything. We take all comers, tooth pain, amputated foot, eye pain, gunshot wounds. So, you really take advantage of all your off service rotations. That would really help you a lot. Um, ER is shift work. You have to be ready for shift work, but I enjoy it because I know that when I'm working, and when I'm off, I'm off. I have off time at home with my family. I'm not on call. No one's paging me. I can plan to take vacations, and I have to have someone cover me or schedule coverage. So I enjoy that. But you see everything. I'll tell you one thing: you won't have a boring life. You will have a very interesting career. Never a dull moment. That's for sure.
Yeah, that's true. Where do you want to go from now, like in your career?
Well, I just started my second run as a medical director, starting in January. So um, just trying to make a success the second time around. Um,
Any challenges you have right now in like the admin part of running a ER department?
we have a lot of meetings, um, and just getting, again, it's my second time around, so just getting to know all the administrative staff, what their priorities are, how best to, get the goals of, their goals are, how can we decrease the door to doctor time? How can we decrease the ER boarding time? How can we uh, decrease the left without being seen? How can we increase patient satisfaction? So just trying to find a way to meet the administrative goals, convey to my staff in a way that makes everyone happy, which is hard to do, but just try the best way to fulfill the goals of administration while keeping my staff happy and feeling successful.
How big is your department? How many people do you have?
As physicians, you mean?
Yeah.
We have 8 to 10 full-time positions, 8 now, and there's 2 more that's joining full-time in July. And then we have 4 full-time PAs and NPs working in the ER as well. And we have maybe 5 or 6 ER positions that are PRN that fill maybe 5 to 6 shifts a month.
So what do you think the trend is for ER as a specialty in terms of like interest from new graduates?
Well, there was a big lull after COVID, but right before COVID, they said we're gonna be over um, saturated. Right before COVID, it's gonna be oversaturated. So it was big, worried about being oversaturated. Right after COVID, we had a big lull. No one to be in ER because that's where all the infections are. No one to be that. But then we're kind of back where we were in terms of the number of residents that join ER. Um, More DOs and internal medicine graduates have joined this past year. But the interest is back to kind of what it was before.
Interesting.
But
Do
during
you
COVID, we
see,
had a lot of older doctors retire. So
yeah. Do you see a lot of physicians that are coming from different other specialties that want to do only ER?
when I was a resident, I had 2 physicians that were internal medicine boarded, had been out in the community for years, and then came back and did their full 4-year ER rotation because they wanted to work on the coast. And ERs on the coast, they demand you have to be ER boarded. Some of the physicians that work with me are internal medicine boarded or family practice boarded, but have trained in the ER and work with us. But usually on the coast in the big cities, they demand you have to be boarded in emergency medicine. So we had 2 that did that. Um, that's why you see the most people who had been internal medicine and went to emergency medicine. I haven't seen a lot of specialists. I actually had one lady who did surgery for a few years and then switched to ER. She was my attending at Barnes.
Interesting. Um, it's an evolving specialty. What do you think is going to happen next in the specialty? Like what's your prediction?
Well, I know right now most of the residencies are 3 years. I went to a 4-year residency. They're pushing to make all the residencies 4 years. So that's one thing they're doing. They're trying to make all of them standard and add an extra year for all the residents. Um, it's going to be more procedure based, I think, because in the hospital, usually the ER doctor is the one that can do all the procedures. So chest tubes, intubation, central lines, ultrasounds. We do a lot of point of care ultrasounds a lot. So I think it's going to be more procedure based and knowing that we are able to go anywhere in the hospital and help with procedures if necessary.
I see. Do you have this? I think from the patient's point of view, the main issue is waiting times. What's your take on this?
So we're actually trying a new model. Starting the end of this month, we're going to start a provider in triage model. So we're going to have a nurse practitioner or physician assistant out in the triage, seeing the patients as soon as they come in and starting the process then. So go ahead and starting ordering the blood work, x-rays, treatments as far as pain medicine, IV antibiotics, and then help triage in the room. This person go fast track, this person go back to the waiting room, this person go straight back to the ER. So we're trying to do different processes to help out with wait times. We're going to expand our fast track area so people who come in with something minor, urgent, can still get in, get out versus waiting longer. So we're trying a whole different things to help wait times because all around the world, all around the country, the amount of patients seeing the ER are increasing. Even with urgent cares expanding, we're still seeing, I think this year we'll see about 40,000 this year, which is maybe a 5% increase from last year, but we've been increasing every year. So we have to find a way to get those patients in and out quickly. And we're just making changes as we can see fit.
Yeah. What's coming up for this year? Anything you have planned in your profession, in your medical directorship, in your department? What do you expect to do?
Well, I said this new provider and triage starts the end of this month. So we expect to dramatically decrease our door-to-doctor times. Hopefully that'll help decrease our total length of stay times for patients, and then hopefully lead to increased patient satisfaction. So that's our goal, to get all those 3 things done. And I have a very positive, I feel about this to be successful. But any new thing, you have to have everyone come in with a positive attitude. There's a lot of people saying, "Oh, this won't work," or "I'm not sure." But I think if we come in with a positive attitude, we can make it work. So.
Yeah, that's true. Very nice. Thanks for coming over, and I hope more people from medical school will choose this specialty because it's wonderful and it's hard, but it's very rewarding. Any final thoughts on this?
Well, thanks for having me. It's been 23 years, and I really do enjoy being an ER physician. I think I was meant to be this. I do enjoy it. So I would encourage anyone with interest to join.
Awesome. Thank you.
Thank you.
Are you a busy medical professional striving to excel in life and work? Stellar Success Podcast brings you the habits and insights of top leaders in medicine and beyond. Discover strategies for balance, growth, and fulfillment in every episode. Follow us on Instagram at Stellar Success Podcast for daily inspiration. Start your journey to success today. Subscribe to the YouTube channel now.
That's a wrap on Stellar Success, leveling up for medical pros with Dr. Tudor Francu. Interested in joining us? Go to stellarsuccesspodcast.com/guest to apply. Stay stellar and level up.